Hi everyone. So now we are going to be starting with the quick revision video of radiology 2.0. So this is the second time over that we're doing this, hopefully better than the last time. So I'm going to be including the relevant theory which you need for the exams in addition to the previous year questions of that unit. So this can be a one-stop shop for radiology. If you've done the main videos, it's great. If you've not done, it's okay. So if you do this one more time so that's consolidated, and that is all you need for radiology, and we will be revising as we go along in our live sessions. Okay, so let's begin. The first thing that we're going to be talking about is general radiology, where I'll be focusing on the four main modalities that we have and what are the salient features, what are the thumb rules. So thumb rules now become very important. Okay, you don't want to memorize the list of what is the best investigation, what is the initial investigation. I want you to understand it very conceptually, that when you do what investigation, and it comes naturally to you. By the time you finish watching this video, hopefully on 1.5x maximum, don't go on 2x because then you lose out on concepts. So 1.5x max, 1x best anyways. So whatever speed you are watching at, by the time you're done with the video, hopefully it'll come naturally to you that what investigation is to be done when. So let's begin then with general radiology. So the four main investigations that I'm going to discuss, just to give you an overview here, is X-ray, CT, MRI and ultrasound. Okay, so these are the four main investigations that we deal with in radiology. What you hear as technician scans, PET scans, SPECT, all of these are nuclear medicine investigation. Nuclear medicine is a whole different MD branch. It is not what I have specialized in, but I shall be teaching you nuclear medicine. There's a small chapter, you get one odd question from that. And radiotherapy, again being a different MD branch, nothing to do with radiology. But still I'll be covering it for some reason. It's very small unit and you don't really get a lot of questions. So both of those we'll be looking at towards the end. In the beginning, I want to focus on diagnostic radiology. So just to give you an overview of these four investigations, X-ray and CT are more or less the same thing. The concept is the same, that I have these rays called X-rays which are coming from the X-ray tube. So now the X-rays are going through and through me. If I take a two-dimensional investigation, what I get is an X-ray. But if I take cross-section, right, my computer takes these X-rays through and through the patient in a three-dimensional manner, and now I can generate any plane which I want. I can get axial images, which are cuts. I can get coronal images, which is anterior to posterior, and I can get sagittal images, which are side to side. So three-dimensional images using a 3D volumetric scanning of the patient is called CT. So the CT, you know, stands for computed tomography. Tomo means to take slices. So you're taking slices, axial cuts here, or basically you are taking multiplanar, multiple planes imaging. So that is what is CT. So both of them essentially use X-rays. If I ask you which has higher radiation, CT has a higher radiation as compared to X-ray, obviously, because now I'm going through and through and it's three-dimensional. So both of them have ionizing radiation. Both of them are going to use the same concept, and hence the density that I see, what is black on an X-ray will remain black on a CT, what is white on an X-ray will remain white on a CT, just that the resolution becomes improved in the CT scan because there's no summation. I'm seeing a section here. So that's what we need to know here. Ultrasound, as the name suggests, uses sound waves, and these are in the ultrasonic range. You can't really hear these sound waves. No, when you get an ultrasound done, can you hear? You can't hear those sound waves because they're in the ultrasonic range. They begin when my hearing power ends. So these sound waves are in the 2 to 20 megahertz range. So they belong to the 2 to 20 megahertz range. What do you think? Will it have radiation? No, these are sound waves. When I'm talking, are you getting radiation through your phone? You're getting radiation through your phone, but you're not getting radiation through your sound waves, right? So ultrasound, remember, sound waves. Ultrasound doesn't have radiation. No ionizing radiation. That's why I can do it in pregnancy. That's why I can use this in children, preferably. MRI now is magnetic resonance imaging. Magnetic resonance. So here, what I'm using is a giant magnet. If you've ever been to an MRI room, there's this huge machine, which is the huge magnet belonging to somewhere close to 1.5 Tesla. Nowadays, we have 3 Tesla. We are going towards 5 Tesla, 7 Tesla. So higher the magnetic strength, higher is the resolution of the images. So this is the high strength magnet. Now you place your person inside this. We try and find a resonance of the frequency of the protons in our body. We have a lot of water, meaning I have a lot of H2O, meaning I have a lot of protons. Now these protons are spinning on their own axis. I want to bring this axis of rotation equal to the rotation of the magnet. So I am finding resonance. When I do that, I get signal, I get image. So this is where I'm using the body's own protons and I'm using the giant magnet to get a signal. So this also does not have radiation. No ionizing radiation, just magnet and protons, right? So MRI actually gives me the best contrast resolution out of all of these. It gives me the best contrast and there is no radiation. So this is very, very good. Just that it takes a long time to get an MRI done. If you've ever been to an MRI machine, it takes at least 30 minutes to get any part done, right? So that's where it is not useful in emergencies because it is time consuming, it is expensive, not readily available. So it's the best, but expensive, takes time. So not useful in emergencies. So this is a perspective that you've now gotten. Two which have radiation, two which do not have radiation. Now we'll see images of these, we'll understand the clinical aspect of these, and we'll see the thumb rules, okay? So let's go. So first of all, what terms will you use? I refer to it as black and white. Now black and white is not something you want to write in your report, that lesion's black, doesn't look good. So then you have to be fancy. So what are the fancy terms that we use to call something black or white? So on X-ray, you want to remember, anything which is black, I'm going to call it as lucent, or I will call it as radiolucency. Anything which is white, I'm going to call it opaque or a radio opacity, okay? CT, MR, ultrasound, all of these, it's same. If it is hypo, it is black. Hypo is the prefix. If it is white, the prefix becomes hyper, okay? So this is simple. As soon as I read hypo, I know the color. Rest of it doesn't really matter. But just to know, on CT, now I'm going to call it hypodense and hyperdense. On MRI, I'm going to call it hypointense, hyperintense. On ultrasound, because it's sound waves is echoing, so it is hypoechoic, hyperechoic. You don't need to remember the suffix as long as you're not a radiologist. You can just do with this and you get your answer. So this is about the basics. We already discussed non-ionizing. The two main investigations become ultrasound and MRI. So anything which is a modification of ultrasound, like ultrasound Doppler, is non-ionizing. MRI, any sequence of MRI, we will learn those, is non-ionizing. X-rays, ionizing. So one are your X-rays, which we also refer to as radiographs. So they definitely use X-rays. Then we have CT scan, computed tomography, which definitely uses X-rays. Apart from this, any study where I am giving contrast and then I'm taking an X-ray, that's called a contrast study, also called as a dye study, also uses X-ray because I'm essentially giving contrast and taking an X-ray. For example, HSG, hysterosalpingography, I inject contrast to the cervix and I take an X-ray, right? So that's contrast study, uses X-ray. Let's take an example, IVP, intravenous pyelography. I inject contrast intravenously, it is going to come to the kidney to get excreted and I take an X-ray to see the collecting system of the kidney, that's IVP. ERCP, endoscopic retrograde cholangiopancreaticography. I go via an endoscope, cannulate the papilla and inject contrast into CPT pancreatic duct. Taking X-ray after giving contrast. So you get the concept. All of these are called as contrast studies. So remember, X-ray plus contrast. So they use ionizing radiation. What is mammography? Mammography is X-ray of the breast. So mammography also uses X-rays. What else? What is the investigation of choice for osteoporosis? It is a DEXA scan. What is a DEXA scan? Dual energy X-ray absorptiometry. So this is where I calculate the bone mineral density using X-rays. So again, uses ionizing radiation via X-rays. Where do we use gamma rays? So gamma rays, remember, come from the nucleus. X-rays come from the extranuclear region, which is basically the electrons. So X-rays are coming from the electrons which are getting emitted, resulting in formation of X-rays, whereas gamma rays come from the nucleus, and that is why we refer to it as nuclear medicine. So all of your nuclear medicine scans are going to be using gamma rays. For example, your technetium-99 scans, everything with technetium, whether it is STAMIB, whether it is DMSA, MDP, whatever it is, all your nuclear medicine technetium scans are going to be using gamma rays. And SPECT, what is SPECT? Single photon emission computed tomography. So just focus on SNP, single photon emission computed tomography is a technetium scan but with a CT. So I can get 3D localization of my hotspot, right? So a comparison would be, this is the X-ray of nuclear medicine, whereas this is CT of nuclear medicine. This is two-dimensional, SPECT is three-dimensional. And then we have PET, so positron emission tomography. So this is where I'm going to be using positron emission now. This is also nowadays combined frequently with a CT scan, making it PET CT or PET MR, but essentially PET uses gamma rays. So this is your perspective on the imaging modalities. Just to give you an idea of the doses, don't really memorize, but the highlighted ones you should have an idea about. So chest X-ray is 0.02 millisieverts. This you definitely should remember as minimum radiation of any X-ray, and that's why we do chest X-ray most commonly. Other X-rays are a bit higher. Mammography, very important, is 0.5 millisieverts. This also I want you to remember. Then now compare it with CT. So see, this is 2 millisieverts. So a CT head is almost 100 times that of a chest X-ray, right? So that's how much radiation increases in a CT scan. So just to correlate, so 2, 5, and 10, as the size of the part increases, the radiation increases. PET is even more. It's 10 to 12 because gamma rays have higher radiation. Now imagine doing a PET CT. A PET CT is usually a whole body CT. So it's around 15 to 17 millisieverts here, and then it's 10 to 12 here. So almost 25 to 30 millisievert is your PET CT. It is the highest radiation of any investigation when you do both of these combined. Barium meal follow through is where you are giving barium to the patient orally and then you take X-rays. So this also is pretty high because we take a bunch of X-rays. We take these continuous X-ray exposures, and that's why the radiation increases. IVP also is pretty high compared to a standard X-ray. So this is what we need to know as a reference. Don't take these numbers too hard. Maybe just the highlighted ones. Okay. So now going on to the images, going on to the clinical aspect and thumb rules. So this is what an X-ray looks like. First things first, side. So what you need to remember here is this is right and this is left. This is going to be true for everything. Just imagine somebody talking to you, like I am talking to you through the video. What is my right side is what is the right side of the patient on the X-ray. So that's how you remember this is right, this is left, and that is how it always will be. Most of the times on the X-ray there will be a marker. If there is a marker, follow that. If there is no marker, right and left. All right, right and left. So this is what you need to know. So this is an X-ray. This is a CT scan, computed. Tomography. What can you observe? You can observe that, ma'am, the bones are looking white. Similarly here, the bones are looking white. The air in the lungs is looking black or lucid. The air in the lungs, when I take a section through it, is looking black. The center mediastinum is somewhere in between. It is neither white nor black. It is gray. When it is summed up, the X-ray it may look a bit white, but still it is intermediate. So that is what you need to remember here on the radiograph and the CT, that bone and air are the opposite color. Bone is white, air is black, and that's how you're going to recognize a CT scan, differentiate it from an MRI when you see that the bones are white. So that's what we got here. Now, another point you want to remember is the difference between these two images. Both are CT scan. What are the difference? The difference are these vessels. The vessels here are appearing white. Why are they appearing white? Because I have injected IV contrast. The contrast media I use in a CT scan is iodinated contrast media. So I've injected through a cannula, intravenous cannula, iodinated contrast, and that is why all of the vessels where the contrast will go is going to appear white. Whereas here, it doesn't appear white. So what do? You compare it with normal muscles. Look at the muscles here. Can you see these soft tissue muscles? If it is whiter compared to muscle, it is contrast enhanced. If it is the same as muscle, we have not given contrast. So this is a non-contrast CT scan, whereas this here is a contrast enhanced CT scan. Got that? When will I give contrast? I will give contrast anytime I want to see organs, right? So anytime we are looking at inflammation or infection, where the contrast intake will be increased because vascularity is increased. Anytime you want to see tumors, we will give contrast because tumors have neoangiogenesis, right? So that is where we're going to be doing CCT. Unless the thing that you want to see is white, you will give contrast. You'll understand that better. But the line is, unless the thing you want to see is already white on an NCCT, you give contrast. Okay, you'll understand that. Now look at this image. Here you can see that everything has changed. Now I'm seeing that the mediastinum has become white, and I'm seeing more details of the lung parenchyma. So this is not a special CT which I have to acquire. It's just the settings, the window resolution that I change, which we call in radiology as windowing. So this is what we call as the lung window, or what you can remember is a high resolution CT. This is what is called as an HRCT or a high resolution CT, where you start to appreciate the respiratory parenchyma, where you start to appreciate the lung parenchyma. So this is HRCT. Anytime they give you any respiratory condition, what is the investigation of choice? You're going to say HRCT. All right. Now, if you're saying something is black, something is white, when do we say that? If I ask you, are you fair or are you dark? If you are the only person living on this planet, will you have an answer to that? No, you are who you are. Yeah. But if you are living with the next person, are you fair or are you dark? You compare, right? So that's what you always do. To know something is black or white, we compare. So then what is the reference? The reference that we use is fluid. So this fluid or distilled water is what I have said is my reference. Now in this CT, you will be like, ma'am, where do I find fluid to compare? So CSF, that's why I pointed to CSF. CSF you can use as your surrogate marker because you're not going to have water everywhere. So this is what is my reference, that is say dark hair, then it is black. If it is whiter than this, then it is white. So in numerical terms, in objective terms, what I use in a CT scan is what is referred to as Hounsfield unit. That is called as HU. So what we use on imaging is Hounsfield unit, HU. Wherein I have given this HU0 a reference to distilled water. That distilled water is my reference. Anything darker is a negative HU, anything whiter is a positive HU. Come to negative first. There are only two things which are negative HU. Let's appreciate this. Can you see here? This is the subcutaneous fat. This is the skin and this is the subcutaneous fat. You can see that the fat is dark and you can see that the air is black. Both of these are negative HU. Air is much darker as compared to fat. So fat, I give it an HU of -10 to -100, whereas air becomes -1000. Okay, so these are two things with negative HU. Coming to positive HU. 20 to 30 is your muscle, your soft tissue that we were using, right? So soft tissue muscle is almost equal to water, just a little bit more whiter. 60 to 90, very important, is acute hemorrhage. When we'll evaluate head trauma, we will see that acute hemorrhage is hyperdense. It is whiter as compared to soft tissue. So do you agree that now when I'm evaluating acute hemorrhage, or another way of putting, when I'm evaluating head trauma, do I really need to give contrast? Unless the thing you are looking at is white, we use contrast. But this is white. So this is where I don't have to use contrast. I'm just going to do an NCCT, getting it because it is white. 100 to 300 is the contrast. It's the iodinated contrast that we're using, which is white. And the whitest of them all is calcium. Calcium meaning bone. So your bone cortex especially is what is made up of calcium, and that is the whitest thing that we have evaluated. So again, can I say that if I want to look at calcification, if I want to look at stones which have calcium, if I want to look at bone pathologies like fracture, what will I do? Do I need to give contrast? No, it's the highest HU. Why do we want to give contrast? I'm just going to do an NCCT. It's anyways going to be white. So again, I'm going to do NCCT. Something which is not even in the scale, goes beyond 1000, is metal. Now normally I don't have metal in my body, but if somebody has a metallic foreign body or an implant or something, now this is even higher than the bone. So this is going to be very, very white. And again, do I need to give contrast? It's lighter than the bone. I don't need to. So here again, the investigation of choice is NCCT. Are you getting the gist of this? So this is what we need to remember here. So now looking at the thumb rule. So it's again something which we will go in a very fluid manner and just understand it very naturally. So CT. So here what you have to remember, where all will I do CT? Anything which is white. So now see if it makes sense. Calcification, calculi which are calcified, bone cortex, acute hemorrhage because of mentally foreign body. So this is everywhere where my investigation of choice is going to be a CT, right? And not just a CT. Now I can also add that, ma'am, these are anyways white, so I'll give contrast. So non-contrast CT scan. Understanding? Right. So now let's see further into the details. What can they ask me? Calcification, they can ask me what is the investigation of choice for intracranial calcification. Any calcification, I know it is NCCT. So further dwelling into it, torch infections is where this really helps me. So if I see this periventricular calcification, what is this pattern for? This is a pattern for CMV, right? So V for V, periventricular calcification. Can you see this ventricle, then around it is this white calcium. So that's CMV. Whereas if you get this white spots here in the parenchyma like this that I'm drawing, that is parenchymal calcification that you see in toxoplasma, congenital toxoplasmosis. So this is where in torch infections, this really helps me, right? Calculi. So now when I ask you what is the investigation of choice for renal calculi, ureteric calculi, or even salivary stones, all of these are stones which are calcified, you are going to say NCCT. The only exception here are gallstones, because gallstones are not calcified. You know, gallstones have pigment, they have cholesterol, but not calcium. They are radiolucent. So that is where our investigation of choice is going to be ultrasound. So you want to remember all stones except gallstones. The answer is NCCT. Look at this CT scan. This is a coronal view. Can you appreciate that there is a stone which is white, hyperdense on the which side? Left side. And you can appreciate this is the ureter. So there is a left ureteric stone that we can see here, resulting in hydronephrosis. You can see this kidney is swollen compared to the right side. So this is how a ureteric calculus will appear. So this is a left ureteric calculus. Okay. Next, bone cortex, especially fracture. So if they ask me what is the investigation of choice for fracture, it's always a CT scan. The first investigation for a fracture is X-ray, but the best investigation is a CT scan, especially in complicated dedicated areas like the spine where X-ray might not be reliable, and do a CT scan to evaluate. Can you appreciate there is a fracture of this particular vertebra? All right, so for fracture, the best is a CT scan. Now, when we talk about bone tumors, for all tumors, the investigation of choice is MRI, okay, because we want to see the marrow involvement. The only exception here, which is a cortical-based tumor, what is it? This is an osteoid osteoma. So osteoid osteoma is the only cortical-based tumor. It has this nidus, this lytic lesion, or this lucent lesion that you're seeing here, or this hypodense lesion is the central nidus, which produces prostaglandin E2, resulting in pain. So we'll talk about all of that. But osteoid osteoma is the only cortical-based lesion where my investigation of choice is a CT. Everywhere else, it's going to be an MRI. Talking about acute hemorrhage now. We saw acute hemorrhage is white, it's hyperdense. I need not give contrast. So I can also say that for head trauma per se, where hemorrhage is the main consideration, the investigation of choice is an NCCT. So look at the CT scan. Can you see this white color hyperdense hematoma? So we see the shape. If it is biconvex, this is EDH. We'll talk about all of this. This is extradural hematoma. If it is banana or crescent shaped, it is a subdural hematoma, right? So this is EDH versus SDH. Investigation of choice, again, NCCT. Metal. So now appreciate this image. Can you see there's a carpenter doing something and a metallic shrapnel went into his eye? So can you appreciate this, that it is not just white, it is whiter than the bone, isn't it? So this is where obviously the investigation of choice is NCCT. Not just that, what is it that I can never do which will be harmful to this patient? MRI, right? Magnetic resonance imaging. Imagine putting a metal in a giant magnet. Your patient is going to have impact and will be harmed. So MRI is absolutely contraindicated. If you've ever gone to an MRI, they're first going to be screening the patient. Did you get some dental implant? Do you have any bullet in your body? You know, so basically you have to rule out metal from the patient. Otherwise you can't do an MRI. The best investigation is a simple non-contrast CT where the metal will shine out. Is this clear? If you ask me that, what is first investigation? See, remember the thumb rule. Whenever CT is the best, X-ray is the first, because X-ray will tell you, okay, something is white. Now you do a CT and figure out where exactly it is, right? So always wherever we are seeing all of these, the initial is X-ray, best is CT, right? So this is our thumb rule page, very important page for CT scan. Just to finish off foreign body perspective right here, right now, they keep asking you this. There are these two children who have either swallowed a coin or aspirated a coin, and it's your job to find out whether it's in the esophagus or the trachea. So what do we do? What you have to see is the face of the coin. If you can see that the complete face of the coin is seen, this is esophagus. So if it looks like this, it is esophagus, whereas if it looks like a slit, it is in trachea. Why so? Because you know that trachea is this C-shaped cartilage. Your coin can't go like this. It will have to live like this because of the cartilage. So that is why the trachea is going to show you the slit, whereas esophagus is distensible. It will show you the full frontal face. Okay, so this is how your coins will appear on esophagus and trachea. On the other hand, what is this here? So you can see now that there are two rims, right? Can you appreciate? Now try and appreciate. Can you see that there are these two rims here? When you see such a beveled margin, this beveled margin is what is a feature of a button battery. Have you seen these tiny button batteries which look like this? So this is three-dimensional, isn't it? So that's why on an X-ray, you're going to be seeing this beveled margin because it's a summation. It's a two-dimensional summation of the same. So a button battery will show you this beveled margin. Last INICT question, right? So this is about the approach. Now they can ask you what will you do next. It's more ENT domain, but just to finish it. So here, anytime you have a button battery, you just need to remove immediately. Irrespective of where it is, you have to remove because these button batteries have alkali, you know, L for liquefactive necrosis. So this is what is the result, and that's why you need to remove it immediately. On the other hand, a coin. In the trachea, again, you have to remove, you're going to remove it with a rigid bronchoscope because rigid bronchoscope, therapeutic, flexible bronchoscope, more for biopsies, more for diagnostic procedures. So remove using rigid bronchoscope. Whereas if it's in esophagus or GI tract, now you need to see the position. If it is stuck here, right, if it's stuck in between the esophagus, then you have to remove it with our GI endoscopy. But if it is in the stomach, if it has reached the stomach, now you can wait and watch, okay, because the narrowest part of the esophagus is cricopharyngeus. If something can cross the cricopharyngeus, it can cross anything in life. Yeah, so you just let it. So you let it be, wait for a few hours, wait for 24 hours, it will come in the stools, right? So that's what you have to do. If it's reached the stomach, wait and watch. If it's anywhere above it, you remove it. So this is about your approach to foreign body. Next, we talk about MRI. As I said, MRI is magnetic resonance imaging. So now we are dwelling into the sequences. So now talking about the sequences here. So what you first need to remember is a sentence that is, or a word that is World War II, or a phrase that is World War II. What do we mean by World War II? Water is white on T2. Now, these are all brain MRIs. First of all, you'll be like, ma'am, what, why? Why is it MRI? So then what will I tell you? I will tell you, look at the bone in all of these. Can you appreciate the bone here? So when you see the bone is black, it's MRI. When you see the bone is white, it's a CT scan. Don't look at this white rim around it. That is not the bone. That is the fat. Do you have bone outside? No, you have scalp fat, and then you have the bone, right? So this is the scalp fat that you see, and then I have the bone. So one observation that I can make is that fat is always white. Whatever be the sequence, fat is white. I'm going to use this up arrow to indicate hyper intensity or it being white, and we'll understand. Okay, whereas bone is dark on all of them. That's how I know it's MRI. So once I've done that, it is an MRI. Now I have to see the fluid. I have to see the CSF. In the brain, we have CSF in the ventricles, right? So we now look at the ventricles. You can see the ventricles are white here, whereas they are black in these two. So as soon as I see water is white, it is T2. So this is our T2 weighted image. Okay, so this is T2. Whereas if it is dark, now it can be two things. For that, I now need to appreciate the gray matter and white matter. Look at these two images carefully. Here you can appreciate that the cortex is darker or gray, and the white matter is white. So gray matter is gray, white matter is white. It follows the name. Whereas on a T2 weighted, it's opposite. You can see that the white matter is actually darker. It is gray, and the gray matter is actually whiter. It is white. So what you will remember, you'll not remember both. You don't remember both, remember one, right? So gray matter is gray, white matter is white. That is what is T1 weighted sequence. Is this making sense? So now first let's finish T1, T2. On T1, fluid is dark. On T2, fluid is white. World War II. Gray matter is gray and white matter is white on T1. Without thinking, I just make this opposite. So far so good. Now look at the third image here. On the third image, can you appreciate that the water, the CSF is dark? Meaning, is it T1 or is it something else? Let's confirm with the gray matter, white matter. So here you can now appreciate that the gray matter is actually whiter and the white matter is actually darker. So this reminds me of T2. Isn't it? So this is T2 where I have suppressed CSF. So such a sequence where the fluid is dark but gray matter, white matter resembles your T2 weighted sequence. That is what is a flare sequence. Flare sequence means fluid attenuated inversion recovery. Fluid attenuated. I have attenuated the fluid by inversion. You don't need to remember the full form. You just have to remember that this is T2 weighted minus CSF. I have suppressed the CSF signal intensity, rendering T2 as it is minus CSF. Why, ma'am? Why did you do all this? I'll show you why. So look at these images. So if let's say I have some sort of pathology, any pathology has edema. So edema is fluid. So fluid is white on T2. So let's say this is my T2 and I have a pathology here. It will appear white and I can pick it up on a T2. I can pick it up on a flare just fine. But then what if I have a periventricular white patch? Seen usually in multiple fibrosis, which is periventricular. Now on T2 I might just miss it because then it's so close to the fluid. But then when I do a flare sequence, now this shines out. So flare is the best for picking up pathology. Can you appreciate this now? That whatever is the edema, whatever is the pathology just shines out because I've suppressed the CSF. Unnecessary whiteness of CSF I have suppressed while keeping the whiteness of the pathology, that is edema. Understood? So flare, what is the only difference? The only difference is that the fluid here is dark, whereas gray matter, white matter is just like a T2 weighted sequence. Clear? So it's T2 minus CSF. And fat we saw is white on all. So now you'll be like, ma'am, if fat is white and edema is white, how do you expect me to pick up bone marrow edema? Because bone marrow has fat, right? Bone marrow is yellow fat. So now if fat only is white, how will I pick up white edema? So you're like, okay, ma'am, you killed CSF once, you are a killer, you kill fat, I kill fat. So this is what you need to remember. This sequence is stir sequence. Stir sequence is T2 weighted minus fat. So now I'm suppressing the fat signal intensity. Getting it. Why are we doing all this? Because bone marrow fat is white. Now if I want to pick up bone marrow edema, I gotta suppress my fat signal intensity so that anything which remains white has to be bone marrow edema. Clear? So bone marrow edema, the sequence is stir. Stir stands for short tau inversion recovery. You don't need it. Just want to remember that this is my best investigation or sequence for bone marrow edema. Next, we go on to some brain special sequences. When you see these black dots here, this is called as SWI, which stands for susceptibility weighted imaging. This comes under the spectrum of images that I call as gradient echo images. Don't need to bother about it. Just remember gradient echo, where I write as T2 star. So this T2 star or gradient echo subtype is susceptibility weighted imaging. This is my best sequence for picking up microbleeds. Small bleeds will appear as these black dots, which I refer to as blooming foci. So these black dots are blooming foci, microbleeds that you see in a condition called diffuse axonal injury. You will study about this. For now, you remember that these black dots are chota bleeds, microbleeds seen in diffuse axonal injury. Next two set of images. First of all, how to identify this is DWI, diffusion weighted imaging. You will not see any of the bone, the fat, nothing. You directly see the brain. DWI, we usually do with another sequence called ADC. It's not a special sequence, it's just a derivative of DWI. So this is diffusion weighted imaging, whereas ADC is apparent diffusion coefficient. You don't need it, hence not writing. So DWI, ADC. Anything which is doing diffusion restriction, what I'm trying to pick up here is the diffusion restricted or not? So if something is restricting, it will be hyper intense or white on DWI and hypo intense or dark on ADC. That's what we call as a diffusion restriction. White on DWI, dark on ADC. At your level, you can also remember white on DWI is diffusion restriction. Now the big question is, who will restrict diffusion? For that, I need to teach you the concept. So here what you will remember is, let's say this is a set of tissue. A tissue has multiple cells, right? And you know Brownian motion. Water is diffusing here randomly, and this is normal diffusion, just unrestricted. Now, imagine somebody having an ischemic stroke. In ischemic stroke, what happens? The blood supply is cut off, your sodium, potassium, ATP pump stops working. Because of which, now what happens? Now your cell is going to swell up, right? Because your sodium and potassium flow is blocked. So this edema is called cytotoxic edema. So now what happens? My normal cells were like this. Here my cells have now swollen. So now what do you think will happen to diffusion? The diffusion is restricted. So this is first example of diffusion restriction, which is stroke. Kaisa stroke? Ischemic stroke. So ischemic stroke will show diffusion restriction. Second, imagine I have a hypercellular tumor. So now again, as compared to normal, I have so many cells. What will happen? Diffusion restriction. So tumors which are hypercellular will show diffusion restriction. Another example, anything which has pus. Now there are no cells, it is just thick pus. Will there be diffusion restriction? Yes. So abscesses will show me diffusion restriction. And one last example, let's say I have a cyst which is filled with this thick keratin-rich fluid. Example, epidermoid cyst. So epidermoid cyst will also show me diffusion restriction. This is frequently asked as a versus question on arachnoid cyst. Arachnoid cyst does not show me restriction, whereas epidermoid cyst does. So what are my conditions that show me diffusion restriction? Ischemic stroke, best and most important. Tumors, abscess, and epidermoid cyst. So my takeaway of diffusion restriction in one line, You now know the concept, so you know this. But in one line, most important, this is my most sensitive sequence for picking up ischemic stroke. Anytime somebody has ischemic stroke, diffusion weighted, can pick it up as early as 30 minutes after the insult. It's just that it is an MRI. And we said that MRI is not readily available. So we will actually understand what is the protocol for stroke. But at this point, you want to remember that even though this is more sensitive, it's not something I do in practice unless I'm working at a specialized stroke setup. Okay. Then what is this color? Suddenly in black and white world, I see some color. So when you see this color coding of the white matter tracts, such a sequence is called DTI. DTI stands for diffusion tensor imaging. So this is what is used for the color coding of the white matter tracts. All right. So this is for white matter. We can use it in tumors when you want to see whether it invades white matter, it displaces what is going on. So that's DTI for you. Clear? Thumb rules for MRI. Now, anything in the brain, remember, anything in the entire central peripheral nervous system, it is MRI. So for your brain tumors, spine tumors, neurogenic tumors, everywhere, neurogenic tumors meaning neurofibroma, schwannoma, all of these, we are going to be doing MRI. Investigation of choice, MRI. For most brain pathologies which aren't emergencies like stroke, I'm going to be doing it MRI. Very, very important. Now, when we talk about CL lung, CL lung, you will say, man, respiratory means HRCT means CCT. But yes, very good. But there is an exception. There is something called as Pancoast tumor. This Pancoast tumor is a superior sulcus tumor which can invade the nerves, the sympathetic plexus, the brachial plexus. So then, what do I need to do? This is the only exception where MRI is investigation of choice. Next concept, bone marrow edema. What did we understand? That the only thing, anytime I hear cortex of the bone, it is CT. But anytime I hear bone marrow, not just marrow, anytime I hear bone marrow, what is going to be my investigation of choice? It is going to be MRI, right? So now what are the applications of bone marrow edema? Anytime I want to see acute osteomyelitis, or I want to see, let's say, sacroiliitis, any inflammation starts from the bone marrow. Let's say stress fracture, very important. All fractures, investigation of choice is CT. The only exception is a stress fracture where you may not have a cortical breach, and the only finding there is a bone marrow edema. So again, for all of these, MRI STIR sequence. Remember, you know the sequence as well. It's the STIR sequence, which is best. Now, as far as orthopedics is concerned, cortex is CT, marrow is MRI. Not just that, for seeing ligaments, cartilage, soft tissue, for all of this, remember, the investigation of choice will be MRI. Fine. So for all of the other ligament, cartilage, soft tissue, it's MRI. So this is all about MR. Going on to our fourth modality, that is ultrasound. Ultrasound, sound waves. Two main things I wanted to understand here. In ultrasound, first of all, the brightness that you see, something is black, something is white, all depends on the reflection of the sound waves. I send sound waves in my body. Are they absorbed? Are they reflected? All of this will decide what kind of a brightness I see. So this mode of ultrasound that we do normally, that I just call as ultrasound, is what is my B mode ultrasound or a brightness mode ultrasound. Now, two effects I wanted to learn here. First, we're talking about the gallstones. So see this. This is the gallbladder. This is the liver. You'll understand in some time. Within the gallbladder, there's something white. That's my stone. So imagine this is stone. I'm sending my sound waves. This stone, very densely packed, is either going to reflect all of the sound waves or it's going to scatter it. Basically, it doesn't let anything go behind it. So what is this going to result in? This is what is going to result in a shadow behind it. So that's what you want to remember, that whenever you see this shadowing, this is what we refer to as stones. So shadowing, also called as posterior acoustic shadowing, but you can only remember shadowing. We see this in stones. All stones will show this, but it is particularly useful in gallstones because they are radiolucent and no other modality will show it to me. So that is stones. Apart from this, shadowing can also be seen in bone because bones are densely packed with calcium. There will be a shadow behind it. And then even air can show me shadowing. But air tends to show me not a dense shadow, but what we refer to as a dirty shadow. It refracts the sound waves. So you can't really see air, on an ultrasound. That's why we call that air is my enemy of ultrasound. Anytime air comes into picture, now my ultrasound is useless because the sound waves can't travel, right? So that is what is the concept you want to build here, that shadow, see the stones, bones, and air. Air is enemy of ultrasound. Now, opposite concept runs with fluid or water. This is a breast ultrasound, we don't need to know that, but there is a lesion here, which is completely black. What do we call such a black lesion? We usually call hypoechoic. But this is so black that it is no echo only, so we made a special term called anechoic. So this is anechoic, and now imagine there is a cyst. It has pani, it has water, fluid, jol inside it, okay? So there is water, and now my sound waves are going through it. Fluid doesn't want anything, it's like go through me, yeah? So it is allowing all the sound waves to go through it, resulting in this brightness behind it. Absolutely opposite of stones. This is so generous, like go through me, have enlightenment behind me. So that is what we see. So anechoic with posterior acoustic enhancement is what is the hallmark of fluid or fluid containing cyst. So this is what is the hallmark of a cyst. It will be black with posterior acoustic enhancement. Having said that, any fluid is going to be the same. So look at this. This is a fast ultrasound. We'll talk about that. So liver, kidney, you have this fluid, black fluid. So you want to remember fluid will be black, fluid will be kala on ultrasound, and echoic, right? So for anything fluid, what is my investigation of choice? Ultrasound. Whether it's a pleural effusion, pericardial effusion, ascites, whatever, it is ultrasound. Clear? So two concepts, shadowing and enhancement. Next, we talk about Doppler. So this is my standard B mode ultrasound. On this, the blood vessels are going to look like this. They're going to be a tubular anechoic channel. Now, when I turn on my Doppler ultrasound, the blood vessel picks up color. So this is what I call as my color Doppler ultrasound, because now there are two things. There is B mode and color Doppler. I refer to this as a duplex ultrasound. Whereas if I put a box and now it also gives me the velocity of the blood in different phases, that is systole here, then diastole, systole here. So if it gives me the velocity also, this is what I refer to as a spectral Doppler ultrasound because it gives me the velocity, and that is what we call as triplex, because now you are seeing B mode, color Doppler, and a spectrum. So this is triplex or spectral Doppler. Now, further details, Doppler shift. What is Doppler shift? I think you have studied this before you became a doctor. But let's say I am a stationary person. There is an ambulance approaching me. When the ambulance approaches me, it gets louder, and as it goes away, it becomes less louder. Why does this happen? So any moving object, depending on its direction, will have a frequency shift. So when the blood is coming towards me, let's say I am the probe, and ambulance is now blood, RBC. When the blood is coming towards the probe, the frequency is positive. When the blood is coming away from the probe, the frequency shift is negative. So that is what I code with color. Positive frequency shift means it is coming towards me, and I give it a red color. If it is negative frequency shift, means it's going away from me, and I give it a blue color. That is how Doppler ultrasound actually tells me the direction of flow. Did you understand? So this gives me the direction of flow. How do we color code it normally? So red is towards the probe, whereas blue is away from the probe. Clear? When we talk about spectral Doppler, now this is going to tell us the velocity of the flow also in different phases. How is the velocity in systole? How is it in diastole? So let's look at the Doppler waveforms. Two kinds of waveforms you want to understand. Look at this. Peak high in systole, reversal in diastole, and then there is one more peak. So there are three peaks that you are seeing. Such a waveform is called as a triphasic waveform. Such a triphasic waveform you're going to see in the normal extremity arteries. So your normal femoral artery, normal popliteal artery, all of these should show you triphasic. If there is any narrowing peripheral arterial disease, the triphasic waveform goes. And that is why the first investigation that I do for peripheral arterial disease is always a Doppler ultrasound to see whether the triphasic waveform is maintained or not maintained. Understood? So this is the first investigation for peripheral arterial disease. Now look at this. You see that the direction is in one phase. It is not going above or below. So such a waveform where it stays on one side is monophasic waveform. This is what we see in normal veins. Veins have no systole, diastole, they are carrying blood back to the heart. So veins have a normal monophasic waveform, right? So that is what you need to remember here. So now with that itself, let's understand what will happen in deep vein thrombosis. So first of all, when we talk about the B mode ultrasound, right? Imagine this is my probe and there's an artery and there is a vein. When I compress with the probe, the artery being elastic will remain as it is. But when I compress, my vein will disappear. So this is what happens when you compress. The artery stays as is, but the vein collapses. So if it is compressible, that is a normal vein. But now imagine this vein having a thrombus. Will it compress? Now it will not compress. So in deep vein thrombosis, what you have is a non-compressible vein. Let's talk about the flow. This is the normal flow that you see here. Fine. So this is my normal monophasic flow. But if the vein has thrombus, will there be flow? Now there will be no flow. So in a DVT, there is absent flow. So that is how we diagnose DVT. And for this reason, for deep vein thrombosis, investigation of choice is Doppler ultrasound. Clear? So this is normal vein versus DVT. Now let's talk about the thumb rules for ultrasound. As we saw, gallbladder stones, or for that matter, anything in the gallbladder, remember investigation of choice is ultrasound. So when they ask you gallstones, you know this is the only exception where CT will not help. It's ultrasound. When we talk about acute cholecystitis, inflammation of gallbladder, again ultrasound is my best investigation. When we talk about a GB polyp, anything gallbladder, we will diagnose it with the help of ultrasound. We saw fluid and cysts were anechoic, posterior acoustic enhancement, investigation of choice, always ultrasound. So whether they ask you pleural effusion, pericardial effusion, ascites, any of it, what will be your investigation of choice? Ultrasound. Pregnancy, the first investigation, the first line is always ultrasound, no ionizing radiation. MRI in a pregnant female becomes difficult. It can be done, but it's used as a problem-solving tool. For anything else, we're going to be doing ultrasound. Vessels is Doppler. So we saw DVT, deep vein thrombosis, investigation of choice is Doppler. For varicose veins, investigation of choice is Doppler. What is this here? So you can see that this is the Mickey Mouse sign. This Mickey Mouse sign is what is seen at the saphenofemoral junction. Saphenofemoral junction is the junction where the great saphenous vein is going to enter the common femoral vein, and this is where we have a valve. So the normal direction is this, where the great saphenous vein enters the common femoral vein, and this is my artery here. So we already said that I can comment on the direction using Doppler. So if the direction is this, it's normal. But what if the valve is incompetent and blood goes back to GSV? That is where I have varicose veins. So for SFJ incompetence, Doppler is the best investigation, right? So that is why for varicose veins, Doppler is the investigation of choice. Coming to arterial diseases now. So when we talk about arterial diseases, as we discussed, the first investigation you will do in anybody suspected to have vasculitis, peripheral arterial disease, we are going to be doing the Doppler ultrasound. That will tell us that, okay, triphasic is not there, it's become biphasic, it's become monophasic, we know that something is wrong. What is the best investigation now? Best investigation is a CT angiography. You're now going to do a CT scan after giving contrast. So that is where now I will see. Again, the contrast is IV. It's not in the vessels, okay? CT angiography is just a CT where I time the scan such that the vessels have the maximum contrast. That is all it means. So now I'm going to evaluate the vessels in 3-dimensional view very nicely. I can see calcification. I can see the exact length of narrowing and everything. So that's why CT angiography is the best. But if they ask you what is the gold standard, the term gold standard refers to something which is not just diagnostic but also therapeutic. And that is DSA. What is DSA? It stands for digital subtraction angiography. So this is where now I puncture the femoral artery, I take a catheter and I go inside the vessel, and let's say this is the narrowing I find. So I find the segment of narrowing. Now with my catheter itself, I can take a balloon, I can inflate a balloon here, and I can dilate this part, I can remove the atherosclerotic plaque. So this is where this angiography is not just diagnostic, it is also therapeutic, because I can also do balloon angioplasty. Okay, so understand the difference between a DSA and a CT angiography. CT angiography is diagnostic, you don't have to do any invasion here. Whereas DSA is invasive, you're going inside, but it is therapeutic. Fine. So this is what is about the concept of ultrasound. Next, we talk about contrast media a little bit. So iodinated contrast is what you use in your contrast studies, right? For X-ray, it is the contrast that I use in CT for IV injection. So the route is IV, or for that matter, any route, right? So in contrast study, you can give it in the cervix, CBD, wherever. So any route is fine for iodinated contrast. What is the prerequisite? I need to get a renal function test done. RFT has to be normal. I will not use it in patients whose GFR is less than 30 ml per kg per body surface area. So this is not used. It is contraindicated in patients with severe renal function impairment. Why? Because iodinated contrast in itself is a nephrotoxin and it leads to contrast-induced nephropathy, CIN. It damages the kidney. So the definition of contrast-induced nephropathy is if I have acute kidney injury within 48 hours of contrast injection. You gave contrast for the CT scan and you have criteria of AKI being met within 48 hours of injection in the absence of any other cause. That's the definition of CIN. All right. What is gadolinium? Gadolinium is an MRI contrast agent injected via IV route only. This is also where my RFT needs to be normal. We'll be doing a renal function test. This is contraindicated in CKD because it leads to NSF. What is NSF? NSF stands for nephrogenic systemic fibrosis. If you give it in a patient with renal failure, this gadolinium chelates are not excreted, they accumulate in the skin leading to fibrosis. So that is what results. SonoView, as the name suggests, is an ultrasound contrast agent which can also be given IV. The unique thing is this is the only contrast agent which is safe in renal failure. So this is something which is actually made up of air bubbles. These are most commonly sulfur hexafluoride micro bubbles. So these are micro, small gas bubbles which I'm injecting in the IV stream. What they do is they increase the reflectivity of the sound waves, hence giving us contrast. But it is safe in renal failure because it is air, so it's excreted via the lungs, right? So that's why very, very important. If I have a patient with CKD, I can't use iodine, I can't use gadolinium. The only thing I can do is a contrast enhanced ultrasound, a CEUS, and that is what is SonoView. The prerequisite, because it is sulfur, you have to rule out sulfur allergy, right? So rule out sulfur allergy because you are injecting sulfur. Coming on to barium sulfate. Now, barium sulfate, remember, is what I use with an X-ray, and this can never be given IV. It's a thick paste. You can remember, like a white thick paint is what we're going to ask the patient to either take orally or as an enema. The rule with barium is it has to remain inside GI tract. If it comes out, it will lead to peritonitis. So this is what is very important, that you have to do a chest X-ray, PA, erect view prior to doing a barium sulfate, because this is contraindicated in any case of perforation or intestinal obstruction. So perforation, obstruction are contraindications of barium sulfate. Very, very important. Not just that, it is also contraindicated in tracheoesophageal fistula and going to the lungs. We don't want that. It is also contraindicated in post-operative patients because then they can have this leakage. So that's important. What can I use in these cases? Can I use iodinated contrast? Yes. So in all of these, iodinated contrast agents are going to be safe. That's the learning point here. And I can give iodinated like gastrografin, iohexol, whatever they give, that's safe, not barium, right? So this is a very, very important table. Now that I'm talking about these names of iodinated contrast agents, let's just figure this out. So there are 4 categories of iodinated contrast media. First, we divide them as ionic or non-ionic. Then we see whether it's a monomer or dimer. Now, these iodinated contrast agents, remember, occurs as a unit. Let's say this is my functional unit of iodinated contrast agent, which is a benzene ring with 3 iodines. This is ionic. So anything which is ionic will be with another pair, let's say sodium. So in any ionic media, I am having 2 particles. One is this contrast, one is this sodium. So this is where ionic will have 2 particles, whereas non-ionic is a single particle in itself with these 3 iodine rings. Is that clear? So this helps us understand. Never memorize this, just understand iodine particle ratio. So first of all, as soon as I see that it's ionic, how many particles should I write? I have to write 2 particles. As soon as I see that it is non-ionic, how many particles? 1 particle. So that's the first half. Now, in any monomer, there are 3 iodines, right? 3 iodine per 1 monomer. So in a dimer, how many iodines? 3 2 are 6. Very good. So here in a monomer, there are 3 iodines. In a dimer, 6 iodine. Again a monomer, 3 iodine, dimer, 6 iodine. So this is how you get your iodine particle ratio. Now you see the lowest iodine particle ratio is here, meaning this is very, very high osmolar contrast agent, almost in the range of 1200. These two are the same ratios, 3:1. So they have the same osmolarity, which is 600. Now when we had 1200, we used to call it high osmolar contrast media. So my ionic monomer are my oldest category, which are high osmolar contrast media. Then I made these and I called them low osmolar contrast media. So these two categories are low osmolar, and then we developed 6:1. Now low was already taken. So then they were like, okay, this osmolarity is 300, which is pretty similar to our plasma. So let's call it iso-osmolar contrast agent. Now because this is iso-osmolar, has the best iodine particle ratio, this is what is the best for renal failure. In any patient who has any renal derangement, right? Obviously we will never use it beyond 30, but if you have a high risk factor where the GFR is more than 30, like somebody who's diabetic, somebody who has hypertension, so somebody who has deranged renal function but is not yet a contraindication, the one we will prefer is non-ionic dimer. Now how to remember the names? Anytime you have too much to remember, my rule in life is see the shorter list and remember that. Same we'll do here. There is only one ionic dimer, which is ioxaglate. Something common to all ionic agents is the name will end with 8. So this is ioxaglate. Any other 8 is going to be monomer. Similarly, non-ionic, the name will end with all. Iodixanol, the name itself tells you it's a dimer. So iodixanol is my non-ionic dimer. Anything else is my non-ionic monomer. You don't have to say. Is this clear? So this is all about the contrast agents. Just two names you can remember. This diaterazolate you see as an ionic monomer is what we use as gastrografin. It is used in place of barium when you have a contraindication. What we use most commonly for CT scan is iohexol, which is a non-ionic monomer. Iodixinol, we don't really use it very routinely because it's expensive. Fine, so iohexol is most commonly preferred. I hope this is sorted. Let's quickly look at the p-values of this section. All of this you would know, so I'll be rushing through it. Which contrast agent is safe in renal failure? So ultrasound contrast agent we saw. Identify the correct statement. HU of water is 0. I didn't know that. CT is the initial investigation of stress for gallstones? Never. It is the initial investigation of stress for other stones like renal, ureteric, salivary, right? So that's what I need to know. It's not even the initial, it's the best investigation. CT is the best investigation for stones. Initial would usually be X-ray or ultrasound. Radiation exposure in CT is 20 millisieverts. Now this is very non-specific. Which part? What are you asking? So it doesn't make any sense. But you remember that head is 2 millisievert, thorax is 5, abdomen is 10. None of it is 20 anyways. CT uses non-filtered X-rays. That's also wrong. We filter the low energy X-rays so that they don't. We filter the low energy X-rays so that they don't contribute to extra dose. Fine. So here one clear cut statement. You know, 28-year-old woman headache is going to undergo a CT scan. What will you ask her? Cochlear implant history is relevant for MRI. Nowadays, even cochlear implant is not a contraindication for MRI, but still you will ask this for MRI. History of fall and hypertension you'll ask anybody, but that does not indicate or contraindicate anything. LMP is very important because I will not want to do a CT scan in somebody who is likely to be pregnant, right? So we always take history in a female of the last period before she undergoes X-ray or CT. But on the same lines, you want to remember that if somebody is accidentally found out to be pregnant after undergoing a X-ray or a CT, what will you do? Will you do an MTP for her or what will you do? Nothing. Nothing needs to be done. Conservative management, even if there is accidental exposure, because it's a very low dose. Even if it's a CT scan, the dose is not enough to cause teratogenicity. There are many papers on this, and as a consensus, anything which is above 50 milligram is what is considered to be harmful, and this is a radiation that we see in nuclear accidents, not a dose that we see in diagnostic radiology. So this is where if you have accidental X-ray or a CT in a female who later was found out to be pregnant, we'll still not do anything. We'll just counsel her. Having said that, don't do if preventable. So always take history of LMP. What is this investigation? Pretty easy. This is thyroid. You can see this is the butterfly thyroid. You can see the trachea. So this is an ultrasound. Now going on to rib counting, something that students face a lot of problem with. This is the last time you face a problem with this. So see the method here. You just have to find out what ribs you can see. Okay, I'm going to teach you the method which is foolproof. So the first thing first, right side or left side. So this is right side. This is left side. Second thing, anterior or posterior. So you can see, we know the ribs, right? They are horizontal behind and then they take a curve and come anteriorly. So my posterior ribs are going to be horizontal ribs, whereas my anterior ribs are going to be these curved ribs. Can you all appreciate this, everybody? This is anterior, whereas this is posterior. So that's the first thing. So when I ask you what is the highlighted rib, half answer you already know that, ma'am, it is horizontal, so it is right posterior. Now which one? So for this, you start counting from what you see. Ignore this small one, even if you see it. You start with the big ribs. So you will be like, ma'am, okay, 1, 2, 3. So you count like how you normally would, and you add 1 to it. So you did 1, 2, 3. Now add 1 to it, it becomes right, fourth, posterior. So that is what you have to do. Let's take an example. You can just stop this video for a second here, pause it, and calculate what is the highlighted rib. Pause and do yourself. So first of all, you will tell me that, ma'am, it is definitely left posterior, and then you started counting. How did you do? 1, 2, 3, 4, 5, 6, 7, and then you added a rib. So 7, 8. So that is what you have to do. One more example. Pause your screen and do this. Right posterior, 1, 2, 3, 4, 5. 5 plus 1, 6. So this is right 6th posterior. Clear? So that's all you need to do. No more seeing this topic again. Whole body CT scan is done in patients, who have polytrauma. It includes head, abdomen, C-spine, but not the limb. So what we do in a whole body CT, somebody who has very severe trauma is, first I will do NCCT head along with C-spine, and after that we do a CCT. We do a CCT of the chest and the abdomen, right? So this includes the entire body. The limbs are only included if there is any trauma to any particular limb. Now talking about pacemaker and aortic valves. So see this, there are 3 kinds of pacemakers. If you see a single lead pacemaker, that lead is in RV. It's like a step-up approach. If you see 2 leads, it is in RV plus RA. If you see 3 leads, it's a biventricular pacemaker where it is in RV plus RA plus LV. So RV is always going to be there. If I see 2, the second one is in RA. If I see 3, the third one is in LV. So now see this. This is the subcutaneous generator of the pacemaker, and you can see these are the 2 leads. One here, one here. Now, where is the lead? So the shorter one, what do you think, is in the RA? The bigger one is in the right ventricle. So this is how you know RA and RV. Look at the option, only one of them. So RV is the answer, right? So pacemaker is sorted. Now we go to valves. So how to know whether a valve, if they label this and ask whether it's aortic or mitral? For that you have to remember a line. Draw a line from the left hilum. This is the hilum, right, where you have the vessels going down. So this is the left hilum. And what is this angle called? This angle is my CP angle, which is costophrenic angle. This is my other CP angle, which is my cardiophrenic angle. This is between the chest wall and diaphragm. Costo. This is cardiophrenic. So you draw a line from the right costophrenic to the left hilum. A for above. If it is above the line, it is aortic. If it is below the line, it is mitral. So that's how you will figure out which valve if they ask you that question. Clear? So this is about pacemaker and valves. What is the modality shown here? You can see the bones are white. This is a CT scan. A lot of students get confused with contrast study. They think that, oh, kidney has contrast, must be contrast study. But now you know better. What have we learned about contrast study? It is when you are going to give contrast and then take an X-ray. So that is what is a contrast study. The moment you see that the bone is white, it's a CT scan. All right. Then what are you seeing here? 35-year-old. Which investigation will be detrimental? Is working with hammer and chisel and a foreign body enters the eye. So anytime you have a foreign body, we know MRI is contraindicated. CT is the investigation of stress. If the following MRI is better than CT, already done it, pan post tumors because I want to see nerves, everything else in the lung is always a CCT or an HRCT. What is this modality? So here what you are seeing is the bone is white, so this is a CT scan. Even if I don't know what barium is, MR is, X-rays, I'll talk about barium as we go along, but as you see the bone is white, you're seeing the intestines, this is CT enterography. Fine, this is what we do as the investigation of choice for small bowel. Remember, this is my best investigation for small intestine because I am going to give this patient mannitol. We give this patient oral mannitol to drink, which is osmotic agent, will distend the bowel loops, and if there is any stricture, like in this case, you will see the narrowing. So for any small intestinal pathology, CT enterography is the investigation of choice. We'll be learning barium soon in the next 5 minutes, but then that's not something which is done in practice. It's more or less theoretical now. Now for any bowel pathology, the best is a CT enterography. They are asking us what is the investigation? Such a silly question. We know that man is Doppler, is triphasic, is normal extremity, and they're asking us what is it? It's Doppler ultrasound. 25-year-old male patient presented with a pulsatile supraclavicular neck mass. What is the most appropriate next investigation? Anytime you have a pulsatile mass, the next thing you will always do is a Doppler ultrasound. Because what does a pulsatile mass represent? Either it's an aneurysm, or maybe you have a lesion which is sitting on top of a vessel. Either ways, I want to do a Doppler ultrasound to figure out if it's vascular or not. So the first thing is always any pulsatile lesion, do a Doppler. Don't stick a needle into it.